Good afternoon. I'm Stephanie Moore, Project Manager for the Association of Community Cancer Centers. I'm eager to introduce Dr. Lee Schwartzberg as our expert presenter for the 19th webinar of the series hosted by the Institute for Clinical Immuno-Oncology, ICLIO. As you may know, ICLIO is an institute of ACCC, is the only initiative to prepare multidisciplinary cancer care providers for the complex implementation of immuno-oncology in the community setting. The ICLIO program provides a host of educational resources and tools such as webinars, newsletters, e-learning modules, tumor subcommittee updates, an immersed IO visiting experts program, case studies in IO program, and live meetings. Now for today's e-course, I am pleased to introduce Dr. Lee Schwartzberg, Executive Director of West Cancer Center and a Medical Director and Senior Partner of West Clinic. Dr. Schwartzberg serves as a professor of medicine and chief of the Division of Hematology Oncology at the University of Tennessee Health Cancer Center. He also serves as the president CMO for Victor Oncology and Oncology Specific SMO CRO. Dr. Schwartzberg was the founding editor-in-chief of the journal Community Oncology and currently serves as the editor-in-chief of the Practice Updated Oncology website. He serves on the editorial board of both the Journal of Supported Oncology, the ASCO Post, in addition to serving as a reviewer for many prominent medical journals, including the New England Journal of Medicine and the Journal of Clinical Oncology. Dr. Schwartzberg is also a member of the board of directors for the National Comprehensive Cancer Network. His major research interests are new therapeutic approaches to breast cancer, targeted therapy, and supportive care. He has also published more than 150 research papers during his oncology career. He maintains a private practice in medical oncology focusing on breast cancer. We are pleased to have Dr. Schwartzberg as our ICLIO Advisory Chair and an active board for our ICLIO initiative. Now for a couple of housekeeping notes. Please feel free to submit questions to our presenter by typing any questions in the box on your dashboard. We also are joined by Dr. Jay Guto of McGivney Global Advisors, who will pose questions to Dr. Schwartzberg following this presentation. The webinar will be archived and available on the ICLIO website. Now I'll send it over to Dr. Schwartzberg to kick off the webinar.
Thank you, Stephanie, for that kind introduction. And what we're going to do today is review ASCO. We just had 3 weeks ago our ASCO meeting, 38,000 attendees, hundreds of presentations, thousands of abstracts submitted to the meeting. As always, it was a deluge of material. And what we're going to focus on today is the clinical data from immunotherapy at the meeting. And I'm just hearing a little noise on my line. If perhaps there could be a mute, that would be wonderful. We're going to focus on the key clinical studies that were presented at ASCO regarding immuno-oncology and focusing particularly on the checkpoint inhibitors and the emerging combinations of checkpoint inhibitors with other drugs, and a novel cellular therapy that is getting a lot of interest, CAR T-cell therapy. And next slide, please. This slide shows you the growth of immunotherapy abstracts over the last 5 years at the ASCO meeting, and it's a good reflection of what's happening in the field in general. So using as a reference 2013, you can see that the curve is really accelerating almost logarithmically, especially over the last few years. And we had almost 4 and now almost 5 times as many abstracts in 2017 compared to 2013. So the number of studies that one sees when going to ASCO, or for that matter, any of the major meetings regarding immunotherapy, is dramatic. And I think it's fair to say that there's not one session that you could have gone to at ASCO and not heard an oral presentation regarding some aspect of immunotherapy as it related to a particular disease or to particular translational science or to even preclinical science. Next slide, please. There were many clinical data presented in a whole host of different cancers, a few of which are listed here, and we're going to focus on many of the ones that are listed here. But again, essentially every type of cancer is being investigated for its benefit from immuno-oncology drugs. Next, please. The highlights we're going to focus on are, as I mentioned, the checkpoint inhibitors in combinations, and those are listed at the top of the slide and by tumor type and by combination. You'll see that the combinations we're going to be talking about are PD-1 or PD-L1 inhibitors with either chemotherapy or other checkpoint inhibitors or anti-angiogenics in the form of Bevacizumab. We're also going to spend some time focusing on the IDO inhibitor combinations, as these generated a lot of interest, and we'll be talking about two different IDO inhibitors. And then we're also going to be talking, as I mentioned, about CAR T-cell therapy, which at the moment is focused on hematologic malignancy. Next slide, please. So before we dive into the clinical data, let's talk about the checkpoint inhibitors from a conceptual perspective. And I think everyone on the call now has likely heard of checkpoint inhibitors. There are many that are on the market. We'll go over the recent history of FDA approval in a minute. But I just want to remind everyone how these drugs work. We know that the immune system is very complicated, and it exists to rid the body of foreign material, whether that material is infectious like bacteria or viral, but also if it includes tumor cells, which are recognized as non-self to the immune system. However, tumors can escape detection from the immune system by expressing checkpoint proteins on their cell surface. And by targeting and inhibiting these inhibitory proteins, intrinsic inhibitory proteins, we can enhance the immune response to the tumor. So the first way we can do that, and the first drug approved, was with CTLA-4 inhibition. And the cartoon shows you that there's an interaction between the antigen-presenting cell and a naive T cell. And the goal of this interaction is to so-called prime the T cell, get it going so that it will eventually generate cytotoxic T cells against the cancer. So this is the first phase of T cell activation of the immune system. The molecule that is an inhibitory, regulatory molecule to not allow our T cells to just get primed without any reason is called CTLA-4, and that will inhibit T cell function. By inhibiting the CTLA-4 with a drug that's called Ipilimumab, we can allow the stimulation of the T cell by the antigen-presenting cell, which can be a dendritic cell or another type of cell, and start the T cell on its path to become a cytotoxic T cell. The other side of the spectrum of T cell activation is shown on the right-hand panel, and this is related to activated T cells, which are killer T cells. These T cells will tend to function uninhibited by killing tumor cells adjacent to them, as you see in this cartoon. However, tumor cells have evolved a way of escaping detection by the cytotoxic T cell by expressing a protein called PD-L1. PD-L1 can be found on the surface of the tumor cells or on the surface of immune cells. And it sends a signal to the T cell through a receptor called PD-1 to shut off the T cell. So what we have devised is two types of inhibitors of this interaction between PD-L1 and PD-1, one of which actually inhibits the ligand, or the PD-L1 itself, which you can see there in purple, and one of which inhibits the receptor, or a PD-1 inhibitor. So there are two flavors of inhibition of the PD-1, PD-L1 pathway. Both of them work essentially to do the same thing, which is to turn off the brake that the tumor cell has constructed against the T cell and allow the T cell cytotoxicity against the tumor cell to proceed unimpeded. So these drugs can be used either in combination or as single agents, and both classes of drugs have activity. Both classes of drugs can inhibit the brake on the immune system at different points in the system and allow killing of cancer cells. Next slide. So before we talk about the ASCO abstract, I wanted to remind the audience that 2017 to date, just like 2016, have been remarkable years for approvals of immuno-oncology agents. This is a list of the FDA approvals that have occurred since the beginning of the year. And you can see that, first of all, 2 new PD-L1 agents were approved in the last few months, and they're highlighted on the slide. Durvalumab and Avelumab approved for different indications. And you can also see that bladder cancer got no less than 6 indications from 5 drugs just in the first 5 months of this year alone for both first line and second line. You also see that we're going to talk about a very important approval for Pembrolizumab, which was disease agnostic. And by that I mean the approval for Pembrolizumab listed on the top of the slide for MSIH or high or mismatch repair deficient extends across all solid tumors. It is not limited to a specific type of tumor like you see for the other indications to date. And this is really groundbreaking. We'll talk more about this in a few minutes. Next slide, please. Okay, so let's turn to the combination therapies that were presented. And we're going to highlight just a few of the many different particular abstracts that we could pick. We hopefully have picked the most important ones and potentially those that will lead to practice-changing measures. So the first one I want to highlight is called Nivolumab and Ipilimumab, the CheckMate 32 study. And this was a study in advanced small cell lung cancer. This was a phase 1 and 2 study. These patients were eligible after first-line failure of platinum-based chemotherapy. And as you may know, we have very few good therapies after first-line treatment. So the study looked at 2 different potential treatments. One, Nivolumab as a single agent in a standard dose every 2 weeks, or Nivolumab in a lower dose of 1 mg per kg plus Ipilimumab given at a higher dose, before doses, so a priming sort of therapy for Ipilimumab, followed by Nivolumab at the standard dose. And you can see the response rates here. So, and first of all, the combination more than doubled the response rate and almost doubled the disease control rate compared to Nivolumab alone, which did have activity as a single agent with 11% response rate. The median overall survival was still fairly modest for either arm, but was doubled with the combination of Nivolumab and Ipilimumab. And unfortunately, there was some increase in grade 3 and 4 treatment-related adverse events, about doubled as well with the addition of Ipilimumab to Nivolumab. And we have seen this across multiple studies, and you will see this as I present other slides, that we get additional benefit from an efficacy perspective, and we do get some additional toxicity as well. The responses in this particular study occurred regardless of PD-L1 expression. PD-L1 is a biomarker that is used in some studies and in some settings to select patients for checkpoint inhibition therapy. The safety in this particular trial with the combination of Nivolumab and Ipilimumab was similar to other Nivo-Ipi studies that were done and that have been previously presented. So the good news is, although the toxicity was somewhat increased with the combination, there were no new safety signals seen in this particular disease state. Next slide, please. Nivo and Ipi was also evaluated in gastric cancer, esophageal cancer, or GE junction cancer. And these were patients who had advanced metastatic chemotherapy refractory upper GI tumors. And 80% of them had had at least 2 prior treatments. Again, this is a very difficult group of patients to treat. Once they fail first and second line chemotherapy, it can be argued that there's little standard of care for these patients. They tend to do very poorly in general with any therapies. This arm of the study had 3 different doses: Nivo at 3 mg per kg as the single arm, and then there were 2 different combinations of Nivo and Ipi at different doses of each, as you can see there. Each of the arms of this trial had between 50 and 60 patients. The response rate was seen in all 3 arms, again, in a group of patients where responses to traditional treatment tend to hover around 0. Seeing responses here is very interesting. It appeared that one of the combinations, Nivo at 1 and Ipi at 3, had an increased overall response rate. The survival for all these patients was modest, but survival would be measured, median survival would be measured in just a few months in patients with any treatment. I think what's really interesting here is the prolonged survival in a group of patients where you would not expect that. And you can see that really in all arms, similar 12-month survival was seen. And the fact that we're seeing patients out in 2 of the arms with over 20% of the patients alive after having failed at least 2 prior therapies is really quite remarkable, and also goes along with what we've seen with other solid tumors, that there is a group of patients, a cohort, who have a prolonged tail of survival once they are treated with either Nivo alone or Nivo and Ipi. If you look at the bottom of the slide here, patients were eligible if they were any PD-L1 status, but a fraction of the patients, roughly 25%, were PD-L1 positive, as defined as at least 1% staining by immunohistochemistry. And as we have often seen in other solid tumors, by using PD-L1 as a biomarker, you can select for a higher response rate, and that's seen across the arms here compared to the upper panel, which were all patients. And here, if you select patients based on PD-L1 positivity of any degree, you're starting to see numbers where 30 to 50% of patients are alive at 1 month, at 1 year. So these and also a few patients at 18 months. So we're definitely seeing some good results here in this hard-to-treat patient population. Again, the treatment-related adverse events were not unexpected and included some GI toxicity. And the investigators concluded that Nivo and Ipi led to durable responses and long-term overall survival in a fraction of patients in these heavily pre-treated patients. And there will be further studies of both Nivo and Ipi in this for these particular diseases. Next slide, please. Okay, another area where Nivo and Ipi showed some very fascinating results was against melanoma, which is metastatic to the brain. And this was the CheckMate 204 study, an open-label phase 2 trial. Now, by way of background, melanoma frequently metastasizes to the brain. And one of the problems that we've had in the past with therapies is that not all systemic therapies have been good at treating brain metastases for a variety of reasons, including the blood-brain barrier. However, there has been some anecdotal data that checkpoint inhibitors can get into the brain and cause good responses. So this was a study specifically looking at patients who had brain metastases with or without systemic metastases to see what the control rate would be. The patients who were eligible for this trial had at least one measurable brain metastases not larger than 3 centimeters. They were not allowed to have neurologic symptoms or be on steroids. However, they could have previously received treatment for their brain metastases with stereotactic radiotherapy. In addition, they could have been previously treated with adjuvant therapies like Ipilimumab in the adjuvant setting or gamma interferon or interleukin-2, but not previous checkpoint inhibitors other than Ipi in the adjuvant setting. And they could have been treated with TKIs if they had a BRAF mutation, which about 50% of metastatic melanoma patients do, and they could have received that therapy. And if you look here at the combination at the low-dose Nivo and Ipi combination, and then Nivo given at full dose after the induction phase, which you saw on a previous slide, 75 patients were treated here. The intracranial response, that is the response rate on the brain metastases, was 56%, and 19% of those patients had complete response in the brain to the combination checkpoint inhibitor, and that's really quite remarkable and gives us a way forward to perhaps prevent the emergence of brain metastases in patients with melanoma. The breakdown of the intracranial versus the extracranial responses are shown in the lower portion of the slide. You can see that patients responded in both compartments, both the intracranial compartment and the extracranial compartment, and the overall response rates were in the 40 to 50% range. The treatment-related adverse events, again, were seen in about half the patients, perhaps a little more toxicity because these patients had brain metastases. There was 8% grade 3/4 neurologic toxicity, and 3 patients had to stop treatment for neurologic adverse events. There was 1 patient who died from immune-related myocarditis, which is something that is not necessarily specific to melanoma, but something we've seen rarely across many different diseases, but it occurs quite unusually, usually less than 1% of the time. Next slide, please. Another hard-to-treat disease is pleural mesothelioma. There's only one line of therapy that is standard for this disease, which is combination of platinum and pemetrexate. Once patients fail that type of therapy, there really is no standard of care. Nivo and Ipi were also investigated in mesothelioma. This was a phase 2 study as well. It was for 2nd or 3rd line patients after progression from the standard therapy. The response rate was 17% for Nivo alone and 24% for Nivo plus Ipi. Control rates hovered around 50% for the combination, and the treatment and the ongoing responses were really quite good, 13 out of 63 patients and 18 out of 62 patients for the Nivo-Ipi combination. The grade 3/4 treatment-related adverse events were increased with the combination, but were still in an acceptable range at 18%. So this is very encouraging data for another hard-to-treat cancer where combination therapy may play a significant role and leads to clinically interesting results when used in these doses. Next, please. Now, I already mentioned the study of Pembrolizumab, the other PD-1 inhibitor that has been on the market now for a couple of years, against microsatellite instability high tumors. And this data was presented at ASCO and simultaneously published in Science, the journal Science, the same week. So I'll go over this in some detail because there are several important points about this. Microsatellite instability refers to a DNA repair mechanism that is impaired across different cancers. Microsatellite high means that you can find these portions of the chromosomes that have instability and have multiple areas in the chromosome that show this, and if that is the case, then that's high MSI. You can also find occasional MSI across different portions of the genome. That would be called microsatellite instability low. But most important distinction is between MSI high and normal, where you don't see microsatellite instability at all. Microsatellite instability is a function of mismatch repair deficiency, which refers to several genes whose protein products work ceaselessly to repair DNA repair, which happens in all cells of our body all the time. So this is a highly conserved biological mechanism. And there are multiple proteins that can be tested by immunohistochemistry to see if they're absent, which would mean mismatch repair deficiency. So they're essentially synonymous. MSI high and mismatch repair deficient represent two portions of the same process, whether you're measuring the protein by immunohistochemistry or you're measuring the DNA effect and looking at microsatellites. So in this particular study, patients were characterized as MSI high by either immunohistochemistry for the proteins or PCR testing of the genes themselves. This study looked at two groups of patients: colorectal cancer patients who were MSI high, and also non-colorectal cancer patients who were MSI high. And most of those were GI, but not exclusively other GI cancers. This was a global multi-center phase 2 trial. These, interestingly, colorectal cancer patients that are not MSI high have very little response to checkpoint inhibitors. However, for the proportion of patients that were MSI high, the response rate was 26%. And in the non-colorectal cancer patients who were MSI high, the response rate was 43%. The disease control rates were even higher at 50% for colorectal and 2/3 of the patients, although it was a very small group of patients, only 21 in the non-colorectal cancer MSI high group. The median duration of response has not been reached in either cohort. And the types of tumors that we saw in the Keynote 158 study included endometrial and intestinal and other GI tumors. Next slide, please. This is data from the Science paper, which goes into a little bit more detail about the responses across 12 different tumor types. And you can see here in the that about half the patients were non-colorectal, which is shown in the pie graph as the red portion. If you look at B, you'll see that in this waterfall plot that across many different cancers, most patients had some shrinkage of their tumor. And if you look at figure C, you see that most of the patients had ongoing responses at 20 weeks of follow-up. Next slide, please. This slide continues to show the data from that trial. On figure D is the swimmer's plot. And an important point about the swimmer's plot is you can see the little dots, which look orange on my screen. Those orange is when the treatment was stopped, which typically was 24 months if patients continued on study. You can see that whenever the therapy was stopped, patients lived a fairly long time after the treatment was stopped, and many of these patients are still ongoing. If you look at figure E and F, you'll see that both the progression-free survival and the overall survival has not yet been reached at a median follow-up of 12.5 months. Now, we don't have the long-term follow-up on this, but the FDA approval for this genetic abnormality of MSI high across every tumor type based on the small patient is really unprecedented and gives us a real precision molecular type of test in order to employ immuno-oncology agents in the form of Pembrolizumab currently to treat any patient that is MSI high. So many of us are now recommending that for hard-to-treat patients that we get MSI testing as part of the routine molecular profile on those patients. Next slide, please. Okay, switching to breast cancer. This is a study of Pembrolizumab in patients who were previously treated with metastatic triple-negative breast cancer. If you detect a theme in many of these cancer types, it's that we're talking about patients that are hard to treat, particularly when we have exhausted their standard therapies. And this was also true in Keynote 86, which had two cohorts. Cohort A were patients who had previously been treated with at least one prior chemotherapy, and patients were eligible for this trial regardless of their PD-L1 biomarker expression. The results are really pretty modest for previously treated metastatic triple-negative breast cancer. Response rate was 5% and the disease control rate was 8%. The median duration of response was good for those small percentage of patients responding at 6.3 months, and the median survival looked reasonable as well. And this is another patient population that unfortunately does poorly. The discontinuations due to treatment-related adverse events was low, and the grade 3 or 4 toxicity is about what we'd expect from single-agent PD-1s or PD-L1 antibodies, and that's pretty low. In this study, only 12%. If you were to look at chemotherapy studies across the board, those grade 3-4 adverse events tend to be more in the 40 to 60% range. So the investigators concluded that the responses that were seen, as you see in the right-hand panel here, that they were durable and that the safety was manageable in patients with pretreated triple-negative breast cancer. Next slide, please. Now, the investigators who presented this study showed one slide of Cohort B. Cohort B is the patients who have been previously untreated in the metastatic setting with triple-negative breast cancer. In addition, the difference between Cohort B and Cohort A, which I just showed you, was all patients were selected who had PD-L1 positive scores. The median follow-up of this cohort is very short. It's only 7 months. But it's very interesting in that in these chemo-naive patients, the response rate was much higher than in the beat-up patients who had received prior therapy, with a response rate in this study of 23%. Duration of response looks very encouraging at 8 months, and there were even some complete responses here. So again, the grade 3 and 4 toxicity was fairly low at 8%. This is very preliminary data on 52 patients, but it is encouraging that in a disease where we don't have any targeted therapies, triple-negative breast cancer, that perhaps early use of the checkpoint inhibitors may prove beneficial. And phase 3 studies combining chemotherapy with PD-L1 antibodies are ongoing at this time. Next slide, please. Now, another place to use checkpoint inhibitors is in the neoadjuvant treatment. So moving these drugs up earlier. If they work in the metastatic late-line setting, which of course they're all approved for now in at least second-line setting in many cases, what about using them earlier? And you could, the theory would be that the immune system is more intact before it's been exposed to the ravages of cancer and chemotherapy and other cytotoxic agents, and perhaps these drugs will work better in that setting. So this presentation was a component of a very ambitious study called I-SPY2. I-SPY2 is a randomized multi-center phase 2 study, which has a novel study design. It has many arms open that are looking at treating different populations of breast cancer patients with a variety of agents, and arms open and closed depending on the responses. So it's what's called an adaptive study. It's already shown some positive results based on the surrogate market of pathologic complete response for other agents in other disease settings. In this particular arm of the study, patients were eligible to receive standard chemotherapy, which was paclitaxel followed by AC as neoadjuvant therapy. That's a standard regimen that's used. But they had Pembrolizumab added to the paclitaxel. So they got 4 doses of Pembrolizumab here as the difference between standard therapy and the experimental study. And there were different cohorts of breast cancer patients who were eligible for neoadjuvant therapy enrolled in this. And that would include the triple-negative breast cancer patients, patients who were hormone receptor positive and HER2 negative, and any patient who was HER2 negative. As you can see from the table, the addition of Pembrolizumab for 4 doses tripled the triple-negative breast cancer PCR rate. And PCR means no cancer in the breast at surgery and no cancer in the lymph nodes at surgery. The patients who were hormone receptor positive tend to have a lower PCR rate to chemotherapy, as was seen here, with a 13% PCR rate. That was also tripled with 4 doses of Pembrolizumab to 34%. And if you looked at the bigger group of all HER2 negative patients, that was also tripled in the PCR rate. This study is designed statistically to predict whether or not these small populations will be positive in a larger phase 3 study. And in all cases, the probability of success in a phase 3 study, which have now been launched in this setting, in the adjuvant setting, are very high, that the addition of Pembrolizumab to standard chemotherapy will improve the adjuvant treatment of breast cancer. If this turns out to be true, this would be hugely practice-changing, because we're talking about tens of thousands of patients per year who potentially could be eligible for this treatment. Next slide, please. Now, one of the questions that has been emerging in non-small cell lung cancer, where we have the longest experience with the checkpoint inhibitors, is what happens if you continue the therapy after the patient appears to progress. So that was looked at in this study with the PD-L1 inhibitor Atezolizumab. And the phase 3 OAK study had previously demonstrated an overall survival benefit for Atezolizumab with a hazard ratio of 0.73 versus docetaxel. So they studied the clinical benefit of Atezolizumab given beyond disease progression. And this was up to the investigators to continue or not based on the clinical features of the patient and how they were doing. They saw that even in patients who had quote, progression, 7% of them who continued Atezolizumab had a subsequent response in a RECIST target lesion. And 50% of them had stable target lesions, even though they had previously progressed. The median overall survival for this selected group was 13 months, which was very good. And that should be interpreted cautiously, because this is a select ad hoc subgroup analysis. But it looks very interesting. So at least we now have some data evaluating the overall survival post-progression when patients receive Atezolizumab. And the next step for this will probably be to formally test whether or not continuing PD-1s or PD-L1s after progression in non-small cell lung cancer improves survival compared to those that discontinue the treatment, which is the standard as of today. Next slide, please. Atezolizumab and Bevacizumab in untreated renal cancer. These were patients who had only received potentially adjuvant therapy or no therapy, and it was a comparison of sunitinib, a standard therapy, Atezolizumab and Bevacizumab. These patients were selected for, or at least had their PD-L1 testing done as part of the study. And there was good activity here. You can see about, across all 3 arms, about a 30% intent to treat activity, which was enhanced dramatically by using the biomarker. So comparing the PD-L1 positive response rate for Atezo plus Bev was 46% compared to 27% for sunitinib only, suggesting that this may be a way forward here. And the progression-free survival was also doubled in the PD-L1 positive selected untreated renal cell cancer patients who received combination therapy. So here's a combination that's not a combination of checkpoint inhibitors. It's a combination of a checkpoint inhibitor and an anti-angiogenic Bevacizumab, which has activity in renal cell cancer. And it looks like that activity has been demonstrated, and this will move forward as well. Next slide, please. Okay, we're going to move on to the last group of combinations, which is with a new class of agents called the indolamine 2,3 dioxygenase inhibitors, or IDO1 inhibitors. Now, what is IDO1? Well, in order for tumors to invade the immune system, I showed you earlier a couple of different ways they do it, but there are many ways that they do it. Another way that tumor cells can avoid immune detection and destruction is by using IDO1. This is an immunosuppressive enzyme that metabolizes tryptophan to kynurenine, and that combination of tryptophan depletion and increased kynurenine decreases the number of antigen-specific T cells. Those are the T cells that are cytotoxic, and concurrently activates regulatory T cells, which shut down the immune system. So if IDO1 goes up, you get these metabolic changes, and it basically shuts off the immune system by another mechanism. So inhibition of IDO1 has been an interesting target for the immune system. Next slide, please. So we have some early studies with the IDO1 inhibitor, epacadostat, combined with a checkpoint inhibitor. And here's a study of epacadostat plus Pembro. And this is across a variety of different tumor types. And you can see the response rates here are quite good, and the disease control rates are even better. In fact, many of the patients who responded have ongoing responses, although they're still early. You look at these percentages, they look quite good. The response rate, for example, in renal cell cancer, 47%, and disease control rate very high. Squamous cell cancer of the head and neck, very high disease control rates, with a suggestion that the addition of the IDO1 inhibitor is enhancing both the response rate and the disease control rate. Phase 3 studies are planned for non-small cell lung cancer, urothelial cancer, squamous cell cancer of the head and neck, and renal cell cancer. And the combinations were generally well tolerated without a lot of excess grade 3 and 4 toxicity. Next slide, please. Epacadostat was also looked at with Nivolumab in similar patient populations, but here including ovarian cancer and melanoma. And again, we're seeing response rates and disease control rates which are better than one can expect with single-agent Nivolumab. Disease control rate, 100% in melanoma, 28 to 36% based on the dose of epacadostat. In ovarian cancer, these appear, they're small numbers, but they appear higher than one would expect with Nivolumab alone. So we're seeing early evidence of additive, at least, activity with the addition of the IDO1 inhibitor. Next slide, please. Another IDO inhibitor, GDC-0919, was combined with Atezolizumab, phase 1B study in a variety of solid tumors. There was some grade 3 toxicities in 13% of patients. Overall, there was a 9% partial response rate in very heavily advanced treated patients, and 24% had stable disease. And the investigators felt that the combination of 0919 and Atezolizumab was well tolerated and demonstrated preliminary clinical activity. So we will see more on the IDO inhibitors, as well as other IDO inhibitors that will be coming into clinical trials, combined with a variety of checkpoint inhibitors. Next slide, please. So to summarize, the checkpoint inhibitors, established checkpoint inhibitors continue to demonstrate clinical benefit, and we saw clinical benefit at ASCO in hard-to-treat tumors like small cell cancer, upper GI cancers, brain metastases from melanoma, and triple-negative breast cancer. We are seeing that this new construct, this new paradigm of MSI high, any tumor type, you pick it by the genomic alteration, not by the tumor type, and use Pembro is now an approved FDA agent. Checkpoint inhibitors are definitely demonstrating enhanced clinical activity in combination with each other, Ipi, Nivo, IDO inhibitors plus PD-1s, or Atezolizumab and Bevacizumab in the right setting. And so the IDO inhibitors look like they're active in a variety of tumor types, combined with a variety of PD-1s or PD-L1 agents. And we'll see much more of this, I'm sure, in the next year. Next slide, please. So I'm going to finish up with CAR T cells, and I'm going to explain what CAR T cells are. CAR stands for chimeric antigen receptor T cell therapy. And what this is what's called an adoptive cell transfer. Basically, the patient's autologous immune cells are removed from their blood through plasma or through leukapheresis, and they are then ex vivo activated and engineered to express a chimeric antigen receptor that recognizes the tumor antigens. You have to have an antigen that you think is present on the particular tumor type in order for this type of therapy to work. Once the engineering occurs genetically, those T cells are expanded and grown ex vivo until they're at sufficient numbers to be packaged and reinfused back into the patient. These engineered T cells then recognize, attack, and kill the antigen-specific tumor cell. So as you might expect, this is operationally a complicated process. It's a cellular product, much like a bone marrow transplant would be, or lymphokine-activated killer cells were some years ago. So there are lots of regulatory steps potentially and operational steps to do this. But we already have vaccines on the market that use an ex vivo approach to engineer, in that case, the dendritic cells. So this is not a novel technology in the sense of removing cells from the patient's body. What is novel is the way that the CAR cells are generated. Next slide, please. There is a downside to CAR T cells, and I'm going to go over this first before you see the fairly striking results. And that is what's called cytokine release syndrome, or CRS. Cytokine release syndrome is the most common toxicity associated with CAR T. And basically, this occurs whenever you give back activated cells that will cause, as part of the natural immune reaction, inflammatory cytokines to be secreted. It doesn't have anything to do with the specific antigen toxicity. Now, there's lots of variability in the degree of CRS among patients. And if you measure the cytokine levels, that may not always correlate to the symptoms. So we have a lot to learn about CRS. We still don't have great biomarkers, and we still don't know, we can't predict which patients are going to get it. It can be mild, and when it's mild, it manifests as flu symptoms, or it can be severe, where there's multi-organ failure and death related to CRS, and these are still occurring. These patients are generally receiving their infusions in an ICU setting and typically in a cellular therapy like a stem cell transplant setting. In addition to the constitutional symptoms, virtually any organ can be affected. So this is protein manifestations of cytokine release, and you really have to have a very dedicated team ready, willing, and able to take care of any organ that could be affected by this. However, with the proper team, with the expectation and the knowledge that this could happen, most patients can be managed through it. It does occur days to weeks after the treatment, and it's not a long-term side effect like we see with the checkpoint inhibitors sometimes emerging. And so getting the patient over the initial hump can usually lead to complete abrogation of CRS. Next slide, please. So first going to talk about using CAR T cells in multiple myeloma. We have many good therapies for multiple myeloma, but eventually most patients do relapse and become refractory. So this was one CAR T cell against an antigen called BCMA that was done in a small patient population, 18 patients. These patients had received a median of 7 prior treatments, and you can see that the dose of the CAR T cells varied by cohort. As they went up to at least 150 million cells given, the response rate was 100% in each of the other doses. Some of these patients had complete responses. Many of them had no evidence of minimal residual disease. They did get cytokine release syndrome, but it was mostly grade 1 and 2, and it resolved pretty quickly. These are very dramatic results for a group of patients who you would not expect would have much activity to any agent. Next slide, please. Another anti-BCMA CAR T cell from a different company had 19 patients with refractory or relapsed multiple myeloma. 18 of them are surviving, free of myeloma-related biochemical and hematologic abnormalities. 6 of them have complete responses and no evidence of minimal residual disease. So these are highly active cells. Next slide. CAR T cells have also shown activity in non-Hodgkin's lymphoma. This is a study for patients that had advanced, aggressive, relapsed, or refractory B-cell lymphomas. It included various categories of B-cell lymphomas, including DLBCL, follicular lymphoma, mantle cell, or primary mediastinal B-cell. These patients had been heavily pretreated for prior therapies. Response rates, again, were dramatic, 86%, and complete response of 50+%. CRS did occur in these patients, but severe CRS only occurred in a very small minority of patients. And a pivotal trial will be moving forward in these refractory non-Hodgkin's lymphoma to show the benefit of CAR T cells against CD19, which is a target that's expressed on lymphoid cells diffusely. Next slide, please. And finally, CAR T cells are also being used in acute leukemia. This is one study that looked at refractory ALL, and this was 11 patients who had exhausted all therapies, including stem cell transplant. 73% of them treated with CAR T cells had a complete response. About a quarter had grade 3 or greater CRS. And a phase 2 study of this CD19-directed CAR T cell therapy in ALL is being initiated now. Next slide, please. So CAR T cell therapies continue to demonstrate very impressive clinical activity in patients with hematologic malignancies, including these very difficult to treat populations with refractory myeloma, NHL, or ALL. Other studies at other presentations at ASH and other meetings have shown benefit in other groups of lymphoid malignancies as well. Next slide, please. So to summarize today's talk, there were only a few of the hundreds of ongoing promising clinical studies focusing on immunotherapy. Biomarkers are being discovered that identify patients eligible for this agent, and we went into great detail about MSI-high. Immunotherapy is becoming, or is now, the standard of care in a number of tumor types, certainly melanoma, many patients with non-small cell lung cancer, bladder cancer, and Merkel cell. And as I showed you, there's clinical activity in other cancers being broadly determined, like breast cancer, mesothelioma, certain groups of colorectal, and many hematologic malignancies. I think we're going to see a continued evolution. I know we're going to see continued evolution of immunotherapy with other drugs added with novel mechanisms of action, including the IDO inhibitors, and we'll be seeing a number of other agents, I'm sure, in next year's ASCO combined with the PD-1s. The estimation that I heard at this year's ASCO was somewhere between 860 to 1,000 active clinical trials ongoing at the moment with immuno-oncology agents, including CAR T cells, which are very exciting as well. Next slide, please. So thank you for your attention, and we have time for some questions.
Thank you, Dr. Schwartzberg, for your very educational presentation on 2017 ASCO highlights. Definitely a lot of information was covered in your presentation. So as you said, we do have some time for a few questions. The first question really has to do with combo immunotherapies. So combination immunotherapies are demonstrating effectiveness, but with increased toxicities. In general, have the approval of combination therapies changed the way you manage immune-related adverse events, and what are your experiences in treating and managing these patients?
Okay, so great question. First of all, the only approval that I'm aware of for combination therapy from the FDA is a combination of Pembrolizumab and chemotherapy. And that, of course, doesn't necessarily increase the immunotherapy toxicities, but it does have additive and non-overlapping toxicities. So far, the combination IO agents, of which the one that has been most heavily studied is Ipilimumab and Nivolumab, has shown increased toxicity. I think it is very important for people that are giving combination, that combination, which has also been shown in melanoma to be effective, although there's great debate about who should get these combinations off study at the moment. If one is contemplating giving a combination of Ipi and Nivo, number one, make sure the doses are correct for the particular disease that was treated, and those doses can vary, and they're still trying to figure out the optimal dose in combination, which could be different from disease to disease, by the way. Second of all, you need a team that is very experienced in dealing with the toxicities, both of the PD-1s and of the CTLA-4, the Ipilimumab, or the CTL-4s that are being tested now, not yet approved. These toxicities can come on late, they can come on early, but the late ones are the ones that patients need to be prompted about, and telling patients that they're on immunotherapy, they can have effects, and to call their care team is one of the messages that we have been focusing on at ICLIO, because patients can be out of the clinic. They're not coming to the clinic necessarily 3 or 4 months after treatment every day or every week or every couple of weeks, and these patients can get sick in a hurry, and they need to know that they're on IO and that they should call their oncologist or a member of their oncologist care team so they get the appropriate therapy to treat their toxicities early.
Great. Thank you, Dr. Schwartzberg. The next question has to do, again, with combination immunotherapies, but it has to do with access. So we know that the immunotherapies are expensive, so combining them, does that sort of limit access to using that, in some patients? And if so, are there ways that patients are able to access the combination immunotherapies, even though they're so expensive?
Well, this is going to be a point of great debate over the next couple of years. If we're going to go to a standard of combined immunotherapy, then we're going to have even more expensive drugs, drugs that list price could be, or a combination list price that could be $250,000 per year, and certainly no one can afford those. So how we get access, particularly those that are underinsured or non-insured, access to life-saving drugs is a critical problem. I wish I could say it's been solved, but it hasn't been. Right now, the manufacturers have been very forthcoming with providing drug off-label and for having foundation support and for having copay support. But how we get the people who study economics don't feel that this is a sustainable model going forward. So many people are thinking very carefully about how we can change the access requirements for patients or the accessibility of patients. We certainly do not want to end up in a situation where we have great therapies for patients that patients can't get. That would be the worst of all worlds. And we need to solve this. It's just as important in its own way as developing these drugs in the first place.
Thank you, Dr. Schwartzberg. So this next question has to do with CAR T-cell therapy. So the CAR T-cell therapy is showing amazing clinical responses to hematologic malignancies, and it looks like this type of therapy might be available soon. Because this is a cell-based therapy, we envision that administering this type of therapy as standard practice might be difficult initially. So, in other words, hospitals would need specific processes in place to be able to administer CAR T-cell therapy. What are your thoughts on this becoming a standard therapy, and how difficult would it be for hospitals to incorporate cell therapy from an operations perspective?
Another great question. So we don't have the answer to those questions yet. What most people feel is that when these drugs are approved, and there is optimism that they could be on the market as soon as by the end of this year, that they will have to be highly regulated in terms of the types of centers that can provide this, at least at first. And it's mainly around the cytokine release syndrome, as I mentioned, which has to be managed. So most people who are talking about this believe that there will be a restricted number of centers that will have access to CAR T cells, and that patients will have to be referred for CAR T cell therapy. As you've already seen, at least right now, the patients who are eligible for this therapy are those that are very late line and have had a lot of effective therapies beforehand. So probably it won't be that difficult to set up the referral patterns before the patient gets to to that condition so that it won't be too difficult to get the patients enrolled once they're eligible, they become eligible. But I think the number of sites that are going to be available are going to be small to begin with. They will probably be cellular therapy sites that already have experience, at least with bone marrow and stem cell transplantation, and possibly a working group like in the old days of the interleukin-2 working group of sites that were in the investigational trials and that had already proven that they had the wherewithal to do the trials and that they had the experience of dealing with the toxicities of CAR T cells. But the questioner is right on. I don't know how we're going to get hospitals to do this yet. It's probably going to take a few years. If those of you who have bone marrow transplant centers, you might start thinking about that now. The accreditation by the FACP, which is the Foundation for Accreditation of Cellular Therapy, and which accredits all the stem cell transplant centers for hematologic malignancies, already has a draft proposal for accrediting centers for CAR T cells as well. So I would definitely start investigating about that. It's going to take a little while to get ready to do this.
Thank you, Dr. Schwartzberg. I think we reached our limit on time. So with that, I'm going to turn it over to Stephanie for concluding remarks.
Thank you, Dr. Schwartzberg, for the engaging presentation, and thank you to our audience for participating. The webinar and slides will be available on our website, accc-iclio.org, shortly, and all the registrants will receive an email with the link. Please also register for our next webinar installments on August 10th, where Brianna Hoffner will present on immune-related adverse events with real-world case studies, and August the 31st, where Dr. Brent Hanks will present on an emerging role of Merkel cell. Please also visit our website, accc-iclio.org, to download and read our latest 2016 white paper. Thank you, and enjoy the rest of your week.